Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
James, we wanted to talk about the longest follow-up we've ever seen in an adjuvant trial, maybe a non-interferon adjuvant trial, I should say. That's COMBI-AD, and we just saw the New England Journal of Medicine paper come out, of which you're a co-author. So we thought it would be apt to discuss that, but maybe before we do, let's just jump into an icebreaker question. In the past, you had told us about your first concert, Pink Floyd, as a teenager. Tell us, presuming you've gone to other concerts since then, tell us what's the best concert you've ever attended? What was the venue, etc.?
Yeah, maybe there's a few that spring to mind. And some of this depends, I think, on your mood at the time and everything else as well. So I don't think it's a sort of purely technical question. One that really stands out for me, which was really magical, actually, which isn't really someone I even sort of listen to a lot, is Tracy Chapman. I don't know if I've told you this before or not. In a jazz festival in the south of France, at a place called Juan-les-Pins. It's this really swanky place on the French Riviera, and it's called Jazz at Johnny. This thing, and they have it in the summer. So it would have been 92, I think. Yeah, 92. So she was only just famous by then and probably still in her early 20s or something like that. And it was just her with an acoustic guitar, nothing else. This amazing stage underneath the pines, Juan-les-Pins, and underneath the pines in July probably. And it was just, not someone I'd really listened to much, but just amazing, actually. So that was good. And other good ones, I've seen Nick Cave once or twice. He's always excellent value for money. And the thing I love about him, I mean, whether you like his music or not, is that if he starts doing a song and he doesn't really like how it's sounding himself, he'll just stop. And then he'll start again, which I just think is really cool. Not many people do that. And another one, third one, I saw Tom Waits once in Paris about, again, a very, very long time ago. And it was just in a really old kind of Baroque Parisian theatre, slightly down at heel. But that was just exactly right for Tom Waits. And he's just an incredible performer on his own as well, just with the piano. So there's a few good ones that spring to mind. Anyway,
and good venues too, good locations.
Yeah, well, that's just luck, isn't it?
Yeah. I'm going to recommend one for your inbox. It's an hour-long YouTube. It's T-Pain. I don't know if you know this. He's the rapper who sort of brought auto-tune into fame 20 years ago, but he's actually an outstanding singer. So the auto-tune sort of made people think, oh, he's not really a good artist. He's an incredible artist, and he does an hour of covers. And it's not just how he does it, it's the jazz band that's with him. It is such an incredible experience. It's incredible because those people who are in that little room witnessing it, might have been filmed in London, are probably experiencing such a once in a lifetime type of listening. So yeah, I went down a wormhole watching that recently.
Oh, I should also say, in the interest of fairness, I've seen The Wedding Present a lot. When I was at college, wedding present gigs were always amazing, but loud, moshing, jumping around, that kind of thing, which is fun as well. But anyway,
just intro outro music for those who are
indeed.
Excellent. Okay. All right. So COMBI-AD. So COMBI-AD is the adjuvant dabrafenib trametinib versus placebo study for BRAF positive melanoma patients. James, I leave it to you to tell us about the details here.
Yeah, so it was a while ago now that the trial recruited, pretty much 10 years. Phase 3, 870 patients, stage 3. So 3A, 3B, 3C at the time. And if it was 3A, you had to have at least a 1 millimeter sentinel node burden. So that's the group of patients, year of treatment, and reported out quite early, in fact, for the primary endpoint, which was RFS, DFS. And so basically the hazard ratio was around about 0.5, something like that, for RFS, DFS, leading to global regulatory approval and I think reimbursement. But for this, if you like, final analysis of the trial, the main question of interest is overall survival. And I mean, I'm just looking at the abstract now, and to cut straight to the chase, the hazard ratio there was 0.8, and the confidence interval there 0.62 to 1.01, p equals 0.06. So just missing conventional formal statistical significance. Maybe before I stop, though, in terms of subgroups, remembering that there were some, most of the people in the study had V600E BRAF mutant melanoma. There were some with V600K mutant melanoma. And if you just do the overall survival analysis in the V600E group, your hazard ratio then goes down to 0.75 with confidence intervals that do not overlap one. So that's maybe an interesting finding. And the trial was positive for distant metastasis-free survival. That's been reported before. Hazard ratio there is about 0.56, and the RFS, which isn't news, was about 0.52. Safety, I think unchanged. There was some detailed follow-up of kind of later events of interest, but I think for my money, nothing new on safety. So that's the quick top line.
Is it fair to say that the breakdown of V600E and K was about 90-10?
Yeah, I'll need to check exactly. I think it's that kind of ballpark, 10-20%. So yeah, so no, K was the total number of patients with K. I'm just doing the maths here. Was 78 out of the whole trial. So yeah, it's about 10%, 90-10. Okay. Yeah.
Yeah, and I say that just to say that 10% impacted the overall survival intention to treat in a way that made it non-significant. But you remove that 10%. We will often like to think, well, that what's the contribution of that? This is sometimes why, trials will exclude uveal melanomas or mucosal melanomas, because if you have even a 10% of that group maybe performing in the contrary to the main, it can really kind of skew these numbers. So this just gives us the understanding of how that can happen with such a limited number. But as you say, when you do this exploratory analysis, just the E overall survival seems to be maintained in addition to RFS. Does that make you think now, James, in your practice or as you're training the next gen, if they have a V600K patient in the adjuvant setting, didn't receive neoadjuvant, they're just in the adjuvant setting, are you likely to sway them away from targeted therapy here because of this lack of OS benefit? Or is that
No, I don't think so. And I think the important point here is that actually the RFS curves, we were just talking about OS, actually for RFS, there is a benefit in the K and the E. Yeah. The numbers are quite small for K, actually, as we've said already, but nevertheless, it looks like it's in the same sort of ballpark, actually, as E, although I would caveat that as well by saying that I think the general experience, let's say in the metastatic setting, where we've probably got a bit more data and we can be a bit more confident about the relative levels of benefit, is that we know pretty well now, I think, that V600K is less sensitive, I think, other things being equal in the metastatic setting to V600E. So I think the interesting question here is that you are seeing an RFS benefit for K. You can't really dispute that, but you're not seeing an OS benefit. In fact, the OS curves are the other way round for K. So to me, that suggests that actually it's something subsequent, some other treatment maybe they had afterwards or something like that, that might be contributing to this effect, if you like, on OS. So if I've got someone with V600K in the clinic, as we talk about a lot, particularly when you're having an adjuvant discussion, you've got a lot of different factors that you're thinking about, and it's going to be benefit risk, it's going to be morbidity, it's going to be competing risk, age group, all sorts of other stuff, okay, intravenous versus oral, blah, blah, blah. And you would, I think, have to put the V600K in that mix as it were, that this is someone who's probably not going to get as much benefit potentially out of adjuvant treatment as V600E, but I wouldn't say that they shouldn't have this as an adjuvant treatment. In principle, other things being equal.
So is it maybe jumping the shark to say, get us to that point? What is that? What does the subsequent therapies look like on this study? So what did the experimental and the control arms receive? Because now we have another therapy in our arsenal. We've had this therapy in our arsenal that has RFS benefit. And maybe just for everybody, I had heard it bandied about many times. When you look at the original report on this, where overall survival was reported in that original New England Journal paper, the OS has a p-value of 0.00 something. It goes on and on. And so I had heard it misinterpreted that OS was positive in that initial report. But of course, Theo Fleming, Brian boundary for positivity was actually much lower, much tighter, if you will, stricter. And so that they had not crossed into that boundary for positivity. So despite it looking like a really sensitive p-value, because we historically think of, as you said, 0.05 as the cutoff, the requirement for OS positivity was 0.000 something, 19, whatever it was. We'll fact check it. And so it was negative in your initial report. And so this is really crucial to see with long-term what OS looks like. But we've always known RFS was beneficial here, and probably with the strongest hazard ratio we have in any of our adjuvant therapies, maybe it's fair to say. So we've got this RFS. We're not so sure about an OS benefit and intention to treat and in this V600K population. So it goes to the subsequent therapy. So tell us about subsequent therapies in this study.
Yeah, so I think the big picture comment there, and do you really jump in front of sharks? I didn't know that was a thing. It sounds like a mixed metaphor.
I feel we're going to have to fact check that phrase and make sure I even used it properly. And what does it actually mean?
Doesn't sound like a great idea. No, but I think the thing with melanoma, the really important thing, and in the modern era, if you like, is we know we can cure patients in the metastatic setting if they relapse with checkpoint inhibitors. That's the massive headline here when we're trying to interpret these adjuvant data sets. And then it comes a little bit back to what we're seeing with the checkpoint inhibitor adjuvant trials and the fact that the kind of original OG 18071 EORTC study, IPI-10, was actually positive for OS, as we've discussed before, in an era when not many people got effective salvage therapies for metastatic disease. So for me, that kind of hangs over the whole thing. Anyway, that was my sort of general point here. But if we talk about the specifics, I'm just going to read it out from the paper now. For the people who relapsed, BRAF targeted therapy was 51% of those in the combo group and 63% of those in the placebo group. So that's what I would sort of tended to expect, I suppose.
Right.
More people. Yeah, because people in the control arm had never had BRAF targeted therapy, likely to be more sensitive to it as well, almost by definition, I would say, because if you've relapsed despite adjuvant BRAF targeted therapy, you might get some benefit from it in metastatic disease, but it's almost bound to be attenuated. And I think such data as exists will show you that. I mean, in a way, the more interesting thing for me is the figures for immunotherapy.
Yeah.
And again, reading 70% in the combination group versus 52% in the control group. Chemo and other things are listed out, but they're about similar for the record, basically. So that's quite interesting for me. And again, we talked about this a bit before. I mean, this will have all played out pre-DreamSeq, is one thing to say. By definition, if you think about when the patients were relapsing and when the study was done, there could have still been some access and reimbursement issues in certain parts of the world. This is an international study as well. But I think it's quite striking that, you've almost got a 20% difference there between people who had treatment with checkpoint inhibitors for metastatic disease between the two arms, circling back to your point about OS. So I think, honestly, quite difficult to interpret in the last, I guess, 5-10 years, these kinds of data.
Yeah. So, I think there was also an exploratory analysis that was done that looked at the median overall survival if you were on the Let me just read this also from the paper. I think this is in the combination group. So in the experimental active arm group, the median overall survival, if you got a subsequent immunotherapy, was longer than if you got a subsequent BRAF targeted therapy. Now, it's hard to know which group got both of those, but I think just looking at how it was reported here, it was 104.6 months median overall survival in that you received immunotherapy in your recurrent state versus 41.8 months. So I think that gets to your point that this BRAF MEK in advanced disease can be active, but it can be attenuated if you've then seen it in the adjuvant setting. And this, of course, is regardless of genotype, of whether you're a V600E or K.
I was going to say the other thing I would throw in there is that this is a clinical trial. Patients were having regular scans. Okay, so when you're picking up metastatic disease, you're all over it straight away. In other words, you have to define it. It's not people are going off and not having any scans. You're picking up small volume, almost always asymptomatic metastatic disease. You're flagging it, right? If you see what I mean, from the purpose of the trial, and probably you're going to be treating it straight away with checkpoint inhibitors. And so, that's kind of, in my opinion anyway, the best group of patients to give immunotherapy to. And it's a pretty impressive survival number that you just said.
Yeah, I guess it gets me back to this V600K question, because you're making me doubt something I had said to a group of community investigator or a community oncologist recently. So was there any exploratory analysis done? And I maybe presume the answer is no, because it would be small numbers, but was there any exploratory done in E and K subgroups by their subsequent therapy? In other words, what percentage of K then got immunotherapy? And it may just be too small to even be meaningful. But it gets me back to this question of how are we counseling community oncologists and our V600K patients on what to do in the adjuvant setting. What I hear you say is, listen, BRAF MEK still makes sense. You've got this RFS benefit. We're just going to be a little bit more stuck if we get to the advanced stage with the K patient. Was that the right or wrong interpretation of that?
I think that's the right interpretation.
And do you have a gaggle of children playing outside your window at the moment?
I won't look. But earlier on someone went past playing like really loud rap music, so maybe this is better than that. No, I don't think there was an analysis. I mean, we can fact check that, but like you say, the numbers would be tiny, and I think really, hazardous actually to try to interpret. So I don't understand that this what's going on with the K patients in the metastatic setting, and I'm not really sure it's ever been well described. I mean, most of our knowledge about this group of patients is fairly piecemeal, actually, and anecdotal.
Do they have a shorter overall survival in general?
I don't know the answer to that. We definitely need to fact check that. I mean, all I really know about it, we don't even see many, to be quite honest. But our Australian colleagues always say that there are a lot of these patients in Australia, and I don't know if they've actually been lined up, as it were, next to the other patients, and then you've tried to control for other relevant factors, of which there are quite a few, if you see what I mean, and then try and work out if the BRAF mutation in and of itself, or the differential BRAF, is really relevant. That wouldn't be easy to do, and even if you did it in that kind of retrospective type of analysis, I'd still hesitate a little bit to read too much into it, I think.
I know. And the problem is if we go back to our Plexicon data and say, okay, look at survival by E and K, maybe that's the purest data set. Those are patients who probably didn't touch immunotherapy after that to much degree, though maybe they did, because if you got the Plexicon drug, you were at a center that probably also had, MDX or ipilimumab. So I guess the reason I'm asking is, and maybe this is a bigger question, when you have a melanoma patient in clinic, because I'm really torn by this V600K issue. They have an RFS benefit. They have an inverted OS benefit. So should I be focusing on let's do everything not to have a recurrence in you, because I'm really not sure how to improve your survival in the long run, and really offer that group the BRAF MEK, which actually is contrary to what I've been saying in my head, but now I can get myself there. Versus it may be other groups of patients where I would say, maybe if you recur, it's not the end of the world because I have such strong therapies to improve your survival or even cure you.
Yeah, well, I'm quite keen on adjuvant treatment in general, I have to say, and paraphrase Mark Atkins a little bit. I'm sure you've heard him say this, that the best case scenario is not to relapse from melanoma. And I think that's right. And I think it's all very well, we talk about numbers needed to treat. We've said this before and all this kind of thing. We look at the curves. You've got a patient in front of you in clinic. Really, none of that stuff, in my experience, helps that much. And I think, the job in appropriately selected patients, et cetera, is to advise them about the best option or options to try and stop them relapsing in the first place. And then, frankly, if someone relapses, all bets are off, actually, because then you've got a different situation in front of you. And again, you have to take that on its merits, I think.
We have not only a different situation, a situation for which we have such limited data, what those patients do. So yes, I agree. So that philosophically, it's a question of, are we over treating everybody just so that we hope whoever's never going to recur gets the benefit from that treatment? We've over treated. That's a question we just have to grapple with as oncologists. A patient doesn't care if they're over treated. If there's a benefit to them, they care if they have to hear it's back. So they care about a recurrence and a relapse. I'm not sure they care about over treatment per se, because we can't specify if we're over treating one individual patient. We know we're giving it to patients who probably don't need it, but it's hard to pick those.
Yeah,
patients.
I mean, if I haven't got on my soapbox about this before, and I'm sure I have actually, I mean, this happens a lot in the kidney cancer world at the moment, where we've got adjuvant pembro, which for the record has got an OS benefit as well. And then there's a lot of resistance broadly, because people say we're over-treating patients. That's the definition of adjuvant treatment.
Yeah,
it's part and parcel. It is. You will over-treat some people. Of course you would, because if you knew who you needed to treat, it wouldn't be adjuvant treatment anymore. Breast cancer, bowel cancer, all the other examples of this. And again, I probably said this to you before, but patient in front of you in the clinic, there's only 3 scenarios here. One, that you're destined to relapse anyway, even if you have the adjuvant treatment. And so then you've wasted your time and you've had side effects. 2, you're not destined to relapse. And, you're wasting your time by having the adjuvant treatment, and you may get side effects as well. And then number 3, the sweet spot, where you're destined to relapse and we stop it happening. And the question is, how big are those groups for the patient in front of you in clinic, in as much as we can say that, because this is all statistics as well. And where does that patient sit on the benefit risk, assuming you have reimbursement and access and so on and so forth. So
I hear you saying, like, if you've got a therapy that effectively improves your recurrence-free survival, reduces your risk of recurrence, use it, because that's the situation that you're in. This is actually, you're reminding me, this is how I talk to cancer patients. So all the data notwithstanding, maybe I don't need to get too heady about it. The situation we're in at the moment is the adjuvant setting. So this is what we have. We know these therapies, this improves your RFS. If your melanoma recurs, we deal with that when that happens. All bets are off, as you say. I tend to tell patients we play the hand that's dealt, the cards that are dealt to us. And if we are dealt cards in the adjuvant setting, we don't play for the metastatic setting, because we don't have that hand yet. We're not in that game yet. And if we play defensively now so that we leave more options for that, we don't know that we've necessarily hit that sweet spot, like you said, or necessarily needed to do that. So I don't want patients to live in fear of metastasis. I don't want them to, this happens a lot also with patients who have some sort of autoimmune disease, where it'll be complicated if we withhold adjuvant therapy and they have a recurrence. They're worried, what happens when I have a recurrence? I still have this autoimmune disease. You're still going to have the hesitation to treat me then. Yes, but let's play that hand if it's dealt to us. If we're not in that scenario now, let's not play that hand.
Yeah, and again, the benefit risk will obviously be different in the setting of metastatic disease, which is separate. But I mean, you can only play with the cards you've been dealt. I mean, that's kind of an important life lesson.
Yeah. Yeah, it takes us to a poker conversation we'll have in a future episode, I think. Anything more to say about COMBI-AD, you think?
No, I think, I mean, we did the trial. It's great to see the data. It's good to see an NEJM. And Georgina Long presented at ASCO. So it's nice, I think, to actually see these long-term data now.
Yeah.
These are drugs that we've only really been using for 10 or 15 years now. We haven't said anything about safety, but actually we haven't seen any new safety signals there. That's pretty important. And I think when we've got the patients in front of us, these kinds of mature follow-up data really give us confidence in talking to patients and counselling them. I think that's important.
And I will make one final point. First of all, I like the curves that are being shown in this final publication on this study. And you see, even at long-term follow-up, even at that, kind of 7 and 8 years, there's still a fair number of patients being followed. So that's kudos. But I think it's probably also fair to say that the curves are starting to plateau both for placebo and for the experimental combination group at about the 5-year mark. So, and at 5 years, there was a really decent number of patients still in follow-up here, but you see 36%, RFS for the placebo group, 52% for combination. And those numbers barely change with this added follow-up. So I think, I think that tells us that that 5-year data really was, it did withhold long-term scrutiny here. So that's good to see too. Doesn't
withstand long-term scrutiny. You said withhold.
Oh, withstand. Yeah, not withhold. It's early morning here for me. So. All right, good. Well, thanks for this great discussion on COMBI-AD, James. Appreciate it.
Thank you.
All right, so fact check now for COMBI-AD, 10-year follow-up, 10-year final analysis, I think is what it was called. But we were in this episode talking about the original citation, and that original report for overall survival, and the p-value, while it had many zeros in it, was non-statistically significant. So maybe you can tell us all that, James. Original citation, p-value.
Yeah, original citation. So Georgina Long and colleagues, John Kirkwood's the senior author, NEJM 2017, November. And so then the p-value there, now this is 3-year overall survival rate. So the numbers are 86% in the combination group versus 77% in the placebo group. Hazard ratio 0.57. Confidence intervals 0.42 to 0.79. P 0.0006. But the point is that this did not cross the pre-specified interim analysis boundary, which was 0.0000, that's 4 zeros, 19. So hopefully that clears up the issue, which I think can be confusing sometimes. You see that kind of level of statistical significance and you think, wow. But actually, it was an interim analysis. So that's that. Now, what else do we need to talk about on this one?
Oh, I think we were talking about, I made a comment about jumping the shark. And there was a question on whether or not that was really a smart thing to do. That actually is how this term is derived. I think it's, if I understand this correctly, and of course I tried to research this, let's hope the internet is as faithful as it can be. It comes from an old Happy Days episode where in later seasons, they were sort of running short of ideas. And there's an episode where the Fonz is on water skis jumping over a shark, which, by the way, the special effects back then could not have been that good. But so the idea is you run through all your great ideas and now you're just pulling at kind of wild and ludicrous ideas. As I say it, I'm not certain I used it properly in the episode. So I don't think I used the term correctly there, just for point of reference. Anyway, that's where it comes from. We also were wondering, we were having a nice discussion about the V600K subset that made up about 9, 10, or 11% of this COMBI-AD study. RFS benefit, no OS benefit. And we were just having a nice conversation of, do we know the natural history of V600K? Do they have if they have an adjuvant therapy that doesn't have an OS benefit, by the way, none of our PD-1s really have an OS benefit, do they end up catching up in the group that metastasizes? Do they have a survival catch up just because of exposure to PD-1 therapy in the metastatic setting? And I think we were both acknowledging we don't know that answer, right? We don't know their natural.
So I'm not aware of any good data, and I think, as we said, that might actually be a nice exercise to try and get some data with the usual limitations, but amongst centres, there will be decent experience, I think, of outcomes for checkpoint inhibitors with BRAF V600K mutant melanoma, which would, of course, need to control for all the sort of established prognostic factors, but nevertheless, that might be a nice little thing to look at.
Well, I think UMelaReg, so I think the European Melanoma Registry might have, BRAF genotypes. And then, of course, MIA, Melanoma Institute of Australia, has a very powerful database. MD Anderson. I wonder if they couldn't combine some of these and maybe just query for patients with a BRAF mutation who developed metastatic disease and have touched both targeted therapy and immunotherapy. Maybe it matters not so much the sequence here, because theoretically you'd have some that would have, anyway, but maybe then we could look at a survival curve of the different genotypes of BRAF V600, EK, DR, K601s, even all the genotypes after they've had exposure to what we consider sort of modern therapy. And so, that might be an interesting exercise to see, but I wasn't sure that I have ever seen anything like that.
Yeah, and I mean, this is more speculation, isn't it? But then, I just wondering out loud a little bit, are there intrinsic biological differences there? TMB, other stuff, parts of the body, all that, so actually there could be a bit of complexity in there of that.
Because you're alluding to K and D and R sometimes in a more sun-exposed location, maybe higher TMB. Yeah, but that's stuff we need to find out, because remember back in the day, we used to feel that NRAS patients didn't do as well with, say, high-dose interleukin-2. And there was kind of that feeling that carried into immunotherapy days. That's, I think, should have been long since debunked, that NRAS patients are fully capable of getting a response to immunotherapy. I don't know that we have any curves that show that an NRAS patient has a worse survival than a wild type, right? Or are you aware of anything?
No, not that I can think of. Now, I remember the story, and I must admit I was never really that convinced, and I don't think I've seen anything, debunking that, as it were. But again, it's an interesting question, I guess.
Okay, another long fact check on another good podcast, COMBI-AD.
But there's no props or calipers. No,
I should have had a screenshot of like the jumping the shark or something. That would have been a good one to have.
Oh yeah, like a blow up shark or something in the background.
All right, thanks.
Thanks.